So I'm going to start by introducing myself. I'm Anthony Stein, and I'm going to chair the session. We are very fortunate to have two really excellent speakers. Martin McKee, who is Professor of European Public Health at the School of Hygiene in London, and has been working in European public health for quite a while. And Marie Casey, who is a specialist in public health in Ireland, who has substantial day-to-day responsibilities around the control of COVID-19. So Martin, if we start with yourself.
Okay, I need to share my screen. There we are. So what I'm going to do today is, can you see that all right, my slides?
Perfect.
Yeah, okay, good. I'm going to give a broad overview of the data in Europe, and then maybe we can talk a little bit more about the policies in the Q&A. So what I have done is to take data primarily from two sources. One is the COVID health data from the Institute for Health Metrics and Evaluation at the University of Washington, Chris Murray and his team who work on the global burden of disease, and they provide a weekly briefing on the situation in each region of WHO. So I'm going to be drawing very heavily on the most recent iteration of that. And also in terms of policies, although that will be more for the Q&A, I'll be talking about I'll be drawing on the COVID Health System Response Monitor that we run from the European Observatory, which I hope people are familiar with. This is just a screenshot from the observatory, and you can see that for each of the, we have situation reports on each country. We have a network of correspondents in many of the countries, not all of the 53 countries in the European region, but many of them. And you can then click on that page and find out the most up-to-date data on the policies that are in place, the responses that are there. You can compare them, and we have also provided a number of syntheses, for example, looking at testing and tracing systems, looking at vaccination rollout and things like that. And so there's quite a bit in the analysis there. Maybe I would just flag up, because we'll be launching it tomorrow at the WHO Regional Directors press briefing. Tomorrow morning, it's all on the press page at the WHO Euro webpage, our report on long COVID, which hopefully will raise the visibility of this condition. Then, so what's the situation in Europe? Well, actually, the news on one way is good in that the rates are coming down, but on the other hand, maybe not so good in that they're very high. Now, of course, we know that we cannot realistically compare the rates of cases in the current period with those in the early part of the pandemic, simply because of the amount of testing. But the key point is that the direction, at least, is in Europe as a whole in the right direction, although, as we'll see later, not everywhere is going the same way. And then we can also look at the death rate. Now that, of course, is more reliable when we compare with the first wave. Fortunately, again, deaths are coming down, but they're still a lot higher than at the peak of the first wave. So quite a long way to go to get back to anything like normality, or even anything like where we were during the summer. We can see a much more varied picture when we look at the death rate per million population across Europe, and we can see the high rates in the United Kingdom, Ireland, France, Spain, Czech Republic, Slovakia, countries that did very well in the first wave but have done much worse subsequently, in parts of Germany and in Hungary, and also parts of Italy. The rates are somewhat lower in places like, well, the countries that have done well consistently throughout the pandemic, Finland and Norway and Iceland, although with some fluctuations, but they have demonstrated that it really is possible to drive cases down and keep them down. Similarly, Denmark doing quite well, and some of the Eastern European countries. Always got to be careful with data from Belarus, but certainly Ukraine and Romania seeming to do a bit better. Now, of course, you will recall that at the beginning of the pandemic, there were some people who produced preprints, never yet published, of course, but preprints suggesting that a high proportion of the population were already immune to the virus, and many more had been infected, but we just didn't realize it. Well, of course, what we're now seeing is that, in fact, even at this stage in the pandemic, a relatively low proportion of the population has actually been infected with the virus. There are a few places where the rates are getting up to high levels, like Montenegro, for example, and some parts of Spain. But in general, we're still talking about rates that are 10% or below in much of Europe, even at this stage. So these much promoted ideas of herd immunity remain as much of a fantasy as they ever were. The situation in terms of the mean effect of R, we obviously need to get R below 1. This is a virus that either goes up rapidly or it comes down rapidly. The idea that you can keep it level at a level other than 0 is, of course, a fantasy. But we want to make sure that it is actually in the green-blue part of the spectrum on this graph. And you can see that in much of Europe it is, but there are a few places that are a matter of concern. Parts of Italy, for example, including Alta Adige and Tuscany and so on. Greece in particular, Bulgaria, Moldova, and Hungary, where clearly more needs to be done. But we would like to see the rates well below 0.75 actually everywhere to get the rates down even further. Then what's happening in terms of people's behavior? Well, of course, we know from trends in mobility measured through smartphone apps that there was a marked reduction in mobility at the beginning of the pandemic, and then that drifted upwards, and with it we of course saw the resurgence in infections, particularly coming out through the autumn. And in Europe as a whole, we're now seeing levels that are low, but not as low as in the first wave. Of course, we also do need to be a bit careful when we look at the Eastern European figures, because these are data from smartphones. We have a paper just coming out in Hungary where we looked at call data records using ordinary phones, not smartphones. They mirror reasonably closely, but not absolutely. So in some of the less wealthy parts of the region, we just need to be a bit careful with the data. Again, the mobility level, what we are seeing is that there are substantial reductions in mobility in the Isles, in these Isles, and in large parts of Belgium, in the Netherlands, in Germany, and Denmark, some of the Baltic states, but much less so. The declines are much less so in the eastern part of the region, a more varied picture in different parts of Spain and in Italy. The testing rollout. Here, England is doing really rather well. Denmark is doing well. Latvia is doing well in testing rates. Now, of course, these are just rates, and the key issue is not how many people are tested. The key issue is how the testing is used. And of course, we don't have data, and that's a more nuanced set of information, which you can get some information off on our COVID response monitor from the observatory. We have, and some of you may have seen our picture of a snakes and ladders board, looking at all the elements that need to be in place for an effective testing and tracing and isolating and support regime. But what this does show is that there's still a really rather low level of testing in some parts of the region, like the Netherlands, for example, like Poland, the Western Balkans, Romania, Bulgaria, Ukraine, and even France, of course, is not doing terribly well either in parts of Germany. We are still at a very, very early stage in the vaccine rollout. And I think this is an area that we need to look at really closely, because some countries are just really struggling to get their act together on this. And but this is just looking at this stage at vaccine hesitancy, the population that is open to receiving a vaccine. And you can see that in the Scandinavian countries, a high level of acceptance in the Isles, the British and Irish Isles, in Spain and Italy. But there are problems in Eastern Europe, in Poland, in the Czech Republic in particular, and in France, where there is a real problem. And of course, also we're seeing in a number of parts of Europe, there's a real antipathy to taking the AstraZeneca vaccine. and not helped by statements by President Macron casting doubt on it and by some rather misleading reporting in the German media. And that, of course, is a challenge because the doses are there, but we need to, of course, people need to be vaccinated. But I think what this is telling us is that we really need to get this sorted out. And the other problem is, of course, the very slow rollout in France. I think what we're seeing is that this is putting public health systems to the test. And unfortunately, in some countries, they're failing. So that's where I wanted to, all I really wanted to say, just in terms of a broad overview of where we are in Europe. But I think it sets the scene, and then I'd be happy to take the questions later.
Okay. Can I suggest that we hold questions until Marie has had a chance to make her contribution, and then we will take questions. If you have questions, they go in the Q&A forum, and we will answer some of those by typing in the answers, and some of those we will ask people to answer the questions online. So Marie, could I pass over to you, if I may?
You can, thank you, Anthony. I asked Anthony a few nights ago what he wanted me to talk about today, and he was saying, well, just talk about the Irish public health COVID response and your experience of it. And that's kind of what I want to touch on today. I think I actually thought a lot about where I started this story, but I think it's really pre-pandemic because, you know, it's very important to consider firstly our preparedness for this pandemic in the first place. And that wasn't strong in Ireland, unfortunately. So firstly, we were starting off with a very, very reduced workforce. We have about 1/3 the staff in public health in Ireland compared to countries like Scotland and New Zealand, which are similar sizes population-wise. We also have difficulties as well recruiting into roles like mine because I'm employed as a specialist, which is unusual in countries like ours, in that most others are employed as consultants. So the contract itself means that it's a deterrent to recruitment and a deterrent to retaining staff as well who are skilled. And I suppose in addition to that, there's other implications with our contract in that we had no teams really working for us. And we had a limited ability to do research or have to hold joint appointments with academic institutions. So immediately we were starting off with a kind of a shaky role within the health service. There was also a chronic lack of planning in relation to the skill mix and staffing we had within public health outside the specialist workforce as well. Gabriel Scally, it was on the call earlier on, but I saw him say that we didn't have a modern public health service in Ireland, and that is indeed true. And it's still true, actually, although that hopefully will improve over time. We also lacked infrastructurally things like HR, finance, IT dedicated to public health. And these all actually have had fairly huge implications as regards our ability to sort out the issues we have had during the pandemic. Additionally, one crucial appointment was left unfilled for many years, which was the director of the Health Protection Surveillance Centre. And that is actually our national epidemiologist. And that role sat empty for 4 years. And after which it was occupied, it's currently being occupied by a temporary appointment. But essentially, that's our Anthony Fauci. That's the Anthony Fauci of our country. It's a very senior role. It's the person who sets the plans in place for pandemics, who looks to the future, who connects with World Health Organization and the ECDC. So essentially, that was not a priority recruitment-wise for Ireland. And it indeed, I think, impacted on our ability to plan going forward as well. This was also down to the contract issue. We had international candidates interested who withdrew once they realised the terms in which they would be employed. I think as well as that, we were also fairly weak on the IT side, which was obviously because we didn't have a function providing that for us within public health. And we had the only kind of substantial piece of IT we had coming into the pandemic was a 20-year-old surveillance system called CIDR. That was reviewed by HIQA in 2019 and found not to be satisfactory at that time. But that again has had issues during the pandemic, has required quite a bit of stabilization IT-wise. We were on the cusp of buying an outbreak management system for public health in Ireland when this pandemic occurred. So we had just received approval at the start of this year to buy a system from Wales, which would actually allow us to record our information about our outbreaks and our advice given, etc. So essentially the medical record for each outbreak, but that is not yet in place because of other commitments for Public Health Wales. And I suppose our own lack of ability to contribute time to do further development. And I think really another fundamental issue is the way in which we were being organised. So coming into the pandemic, we were under the Health and Wellbeing Directorate and the HSE, which had just been disbanded, and we were being transitioned across to the to Colm Henry's office, the Chief Clinical Officer's office, and under his direction. So we were kind of in transition, and there was an awful lot of development happening around roles and discussions about how we might reform public health in Ireland. So it was a very transitional time and quite a bad time to enter a pandemic. Another challenge, and I think this is something that is very difficult for public health as well, we had not really emerged through the HSE reforms or being reformed at with the same pace as other parts of the health system, like the community healthcare organisations and the hospital groups, which essentially means we have, except for my area, different catchment areas to those organisations. And in a pandemic, when you actually have to pull together and work side by side with your community and hospital colleagues, having different catchment populations makes that a lot more challenging. So some public health departments will have a number of CHOs and a number of hospital groups to deal with, and that just adds to the complexity and the issues that we face on a daily basis. Then going back to our planning and preparedness, we had a flu plan, a flu pandemic plan, which is very different to COVID. And I think, like many countries, we had that. And I suppose what's different about a flu pandemic is that, just drawing on our experience from the 2009 one, contact tracing tends to end quite quickly in flu pandemics because you have access to antivirals, you have access to a vaccine that can be tweaked to include the new type of flu as well. So your way out of it is quite a lot quicker. And we didn't really have it in our planning or our infrastructures to actually deal with the situation where we'd be contact tracing 13 months into a pandemic, and where we would need systems and staff to do that. Our response in the initial stages to COVID in public health in Ireland, really, in the initial phases, people like me were doing the contact tracing because there was nobody else to do it. But our contact tracing centres were set up nationally alongside public health departments to actually do the big bulk of contact tracing, which was really important because we got to hundreds of cases a day fairly quickly, and that was far outstripping our staffing in public health. However, as time has progressed during this pandemic, this lack of regionalisation of contact tracing is a bit of an issue, because fundamentally, at the moment, contact tracing centres, they contact a person who's taking a call, can be talking to someone from Cork 1 minute, Kilkenny the next minute, Dublin the next minute. And that essentially means that you lose the ability to have an overview of what's going on in your region and to pick up on patterns and things that are really important. And I suppose they're particularly important if you're talking about source investigation, because in our department, we, for as much time as we can, and when things are a little bit quieter, we call all our cases after they've been contact traced and see if we can layer any additional knowledge on top of it. And sometimes it's about layering the histories of hundreds of cases on top of each other and hearing common signals, like there was a communion or there was a party or something like that. So these are the kinds of things that are missed when contact tracing is very national and it doesn't have this very regionalized connection. And that's something that I hope will improve over time. That's something I hope we move towards, because really we can't do reverse contact tracing or source investigation, as I first call it, without that regionalization. Another thing, I suppose maybe it might be useful for me to also say what we do in public health in the regional departments, because seems to be a lack of understanding at times. So in regional departments, we manage the outbreaks, we investigate the clusters. And when I say we manage the outbreaks, I'm the person who phones up you know, the nursing home or the factory, or a colleague of mine will phone a school and actually gather the information and make the public health risk assessment of what needs to happen next, who needs to be tested, does, you know, what measures need to be put in place, what possibly went wrong to create the circumstances that gave rise to this outbreak in the first place. So we do this kind of risk assessment and analysis, and we look at the cases and the transmission patterns, and we interpret those as well and make plans based on them. So it's quite a complex job, and there's really not that many of us doing this work. And I suppose we've struggled very much so along the way in getting staffing to help us support us in this kind of this area of work as well. We do a lot of contact tracing, complex contact tracing in workplaces. We do them in direct provision centres, nursing homes, schools, etc. So the contact tracing centres take care of the individuals and on the simplest level, and generally it's their household contacts and friends and things like that, and we take care of the more complex situations that need to be evaluated. So I suppose the thing is that I had to think this morning about the key issues or the key challenges we've had along the way. And the first thing about COVID is that's actually really, really hard to deal with as a public health issue. What makes it really hard to deal with is you've got this really wide spectrum of infection, of symptoms. So you have it from the very mild, very minimal, maybe no symptoms, all the way up to somebody who is in an ICU. And that means sometimes it's very hard for us to find the cases, and we have to be very careful and, you know, really go for cases and look for them, because sometimes they're not that findable. Another thing that's an issue is really the pre-symptomatic spread that's possible as well. So people saying to themselves, you know, I'll be good if I get symptoms, I'll be good if I'm sick. That's actually not that kind of approach isn't enough in this particular disease, because you may have transmitted by the time you realize you've got a problem. Another issue as well is the long incubation period. So the incubation period is the time between when a bug enters your body and infects you and you start to develop symptoms. And the incubation period is about 2 weeks in COVID. So by the time you start developing symptoms, the event or the situation that may have led to that is a good bit behind you. So you may be behind. I find in reality that we're behind the curve, and we have to work very, very hard to catch up and prevent further spread. Another issue for us along the way, challenging, were environments like nursing homes. Nursing home outbreaks are particularly challenging. I suppose the first thing is really that they're set up as homes and not healthcare institutions, so don't have the same culture or approach to infection prevention control as like a hospital environment where a lot of people would have. What's difficult too is staffing in that sector as well. There's, you know, the staffing is as they need, just what they require. And when you get an outbreak in a setting like this, the staffing can really reduce very rapidly, and it can be very, very difficult to find replacements to come in and work in these settings. So, you know, firstly, it's quite difficult to find nurses at the moment, but then additionally, to find nurses who are willing to come into a place that's in an active outbreak can be very challenging. I suppose what's also challenging too is the amount of infection prevention and control supports that were in place to them before the pandemic, and the knowledge of the staff in this area as well, because these settings weren't designed to be healthcare or run at that level, so they really lacked that culture. Another issue that we've had along the way is around sick pay and people's ability to actually stay out of work if they are unwell, and to avail of that. You know, we've all struggled to work with colds over the years, and in the last year we haven't been able to do that, and that has really put a lot of pressure on a lot of people in a lot of sectors, particularly in the lower paid sectors as well. Few places that really have issues are direct provision and the traveller settings as well, because of living closely together. That just creates an amplification of any outbreak. When you have any situation where you have lots of people living closely together, that's going to amplify an outbreak. So cases will come in there, then spread, and that will create further spread outside in the community as well. The same phenomenon would be seen in nursing homes too. So these are very challenging from a public health point of view. And I think, you know, we've been very vocal around the need for supports for people in these communities. And I think in general, there has to be greater supports for communities in relation to isolation and quarantine as well. Not everyone finds that terribly easy. And also, you know, there are practical sides to it as well around getting food, having income to order food, ordering food online and having credit cards to do these things. So a lot of these things cannot be taken for granted. I think in general, one of our major issues more recently is a messaging fatigue. I think people are quite tired at the moment. And I think we're noticing a kind of a slip on the ground in people's adherence to the guidance, which I can kind of understand at this stage because people are tired. But it's definitely contributing to holding the virus numbers at this level that we're observing over the last while. So that's why we seem to be stalling a little bit. I think something that we've particularly learned during the pandemic in public health is the importance of regional public health. So in many countries, and maybe Martin would be able to talk a lot more about this, many countries, the push has been very much to centralize public health and make it a central function because, it makes sense. You're dealing with a population. Why shouldn't you work at a national level? But in reality, you have to work at a regional level to address regional issues because I know my population locally. I know the housing estates. I know the pubs. I know the restaurants, and I also know a lot of the local partners, like people in the hospital group, the community healthcare organisation. For example, in the outbreak I'm dealing with at the moment in UL, I know the academic partners locally, so I'm able to find out what's actually happening on the ground and tailor a response to that. I was speaking to a colleague from another country, I won't say which one, and they had a very centralized public health function. And he said one thing that they'd really learned, he said, is that it just wasn't adequate to COVID response, that they really had to start pushing more resource into their regional teams to actually allow more tailored responses and tailored messaging as well, because people really want to know what's going on in their area and what's driving the numbers in their area. And I suppose that helps them with their own risk assessments when they go out in their daily business. But it also means that we can do more nuanced control measures. I wanted to give you a kind of an example of how that has been working recently for me as well, because, and I've spoken about this in public already, but I think it just shows the value of local working together. So when I'm dealing with an outbreak in a nursing home or somewhere like that, it's very easy for me to investigate that because everybody is in a contained area. I know their names, I know where they're from. I know I can request tests for them. I can give advice based on where they are. Very simple. When I'm dealing with an outbreak like I'm dealing with in the student population in our local area, that's far more challenging because I don't know their names. An awful lot of students use their parents' addresses as their communication address. So it's actually quite difficult to find these people and test them and give advice and communicate to them. And I suppose in our area, I've been very lucky. I've worked with the university locally and borrowed ideas from other places and worked with their local community swabbing and testing and put a system in place in our university where students could self-book tests. And so I put this system in place with the IT department in UL so we could have it in case any more blips happened after the second wave, where undoubtedly the student spread was a big driving force for the increase in cases in our region. So it's enabled us to have a much more rapid response this time round. And that's something that was very locally developed and locally driven. And also this learning that UL have put in place, this system, they've also shared it with the other academic institutions in our area too. So I'm able to tailor a response very much at a regional level. So I think I'll probably stop talking at this stage because I've talked for long enough, but I think that's the value of public health. And I think it's the value of actually putting resources into public health at a regional level, because it enables us to go case finding like I'm doing right now. I'm trying to take every opportunity from now onwards to suppress our numbers. I'm probably going to increase the numbers in the short term to actually find these cases, but that will actually hopefully have a positive impact in the longer term where the cases can be brought under control. So essentially, I think just in future, in going forward in public health, the staffing issue is, some of it has been sorted right now, but more needs to be done on that for sure. We also need to get a more diverse workforce in place as well. And I also think we need to get a public health approach to recovery from COVID as well. So we need to be thinking about how we're going to plan to deliver services in the post-COVID situation, and also how we're going to plan our social and cultural recovery as well from the difficult year that we've just had. And I suppose another thing I wanted to say too is we need to make sure that we remember the marginalized groups that I spoke about earlier. They need to be vaccinated. They need to be vaccinated, and plans need to be made to vaccinate them in a very different way to the rest of the population, because we know some groups are slow to uptake vaccine, and we shouldn't, one size does not fit all in this scenario. And maybe just two last closing thoughts. I think there's a few, the whole pandemic has taught me a lot and made me reflect a lot about public health in the global sense. And firstly, that public health struggles very much to get funding globally, as well as Ireland. Nobody wants to pay for health insurance or house insurance. But the fact is that pandemics are likely to increase in frequency as time goes on. So it's very much a biosecurity issue. And secondly is that, when I was doing the work around IT systems for public health and procuring one, that's what I did before, an outbreak management system in public health, there weren't a lot of solutions globally. The public health market is not a profitable one. So it means that an awful lot of systems for dealing with outbreaks had to be developed during this pandemic. We've had to buy a call center software system from Microsoft and adapt that for contact tracing. Other countries have done similar things. So the market essentially doesn't work because there isn't a market, because there is rarely funding. So if we want public health globally to have decent infrastructure, this is something that really needs to be looked at. Thank you.
Okay, thank you very much. There was, I think, two very interesting contrasting perspectives on what's happening in public health. Martin, do you want to say a word or two just about your understanding of the range of public health practice across Europe?
I mean, there's an enormous range between the really quite effective and the point that was being raised about should it be local, should it be central? I think the answer to that question, maybe I'll pick up on, because I think the answer is that public health should be represented at the level of government at which the appropriate decision is being made, whatever that is. So there are going to be differences between a centralized country and a regionalized country, like in particular Germany or Spain or Italy, or an extreme version, Switzerland. And the reality of it is that almost everywhere public health has been underinvested in for far too long. And we've seen particular reductions in investment over the last decade in many countries, particularly in the aftermath of the financial crisis. There is also a big problem in a number of countries. I mean, Ireland we know about, but also in Germany and some other countries, about the status of public health, particularly in relation to, for the medics anyway, other medical specialties. And that's something I think that needs to be addressed too. But in general, some countries have got quite strong structures. Italy, I would single out. Spain did have, but Spain has suffered, there was very strong public health a decade ago there, but it suffered a lot from underinvestment. And the Nordic countries in general as well have done well. Eastern Europe, actually, Central Europe, paradoxically was doing well at the beginning, partly because they still had a very old-fashioned public health structure and a public health approach that was very much based on the threat from infectious disease. And it actually responded quite quickly, although it lacked the more nuanced sort of behavioral science aspects and so on. But at least there was an infrastructure in place. So I think the answer is hugely variable across Europe, and it always has been, and it's sort of defied any attempts to get any degree of harmonization, despite efforts by the Association of Schools of Public Health in Europe or UFA. Yeah.
I have too many controls here. Thank you both. Thank you both very much for two really good speeches, two really good contributions. I think I understand both the local and the continent-wide story better than I did an hour ago, so that's really helpful. We have a number of questions. Perhaps I might go through them from the top. So Sharon Callan has asked, what can the general public do, essentially? And I don't know if anyone wants to say a few words about the We Can Be Zero campaign. Perhaps Simone, if you would like to say a few words about that.
Thanks, Anthony. WeCanBeZero.com, if anyone wants to come and join, is the people's campaign that has come from people like you asking questions like this. What can I do to contribute? From us looking at what Marie Casey's been saying and her colleagues for a while now, why this hasn't been resourced, especially given that we are a year into the pandemic. What can people do to say to government, to their TDs publicly about what needs to be done, looking at this expertise and what needs to be done. So the first place to go is to WeCanBeZero.com and subscribe and join the campaign, because the more numbers and the more voices that go behind the poll results that we have, the better. Then we're able to speak as one voice in that way, or to start a branch. There's Cork and Kerry and Tipperary branches now for We Can Be Zero. So looking again at how public health works best at a local level, getting people in communities to ask the government to play their part in getting these shared islands to zero, but really focusing on the local and those communities. So.
Okay, that's very helpful. So thank you very much. There's a question about face masks. Does anyone know, from Rebecca Moore, does anyone know why face masks are not mandated in primary schools in Ireland, where we have relatively large classes and no new extra safety measures in school? So what are people's thoughts on face masks for children in primary school? Is any views on that?
Well, they are being used in a number of countries, but I'm just struggling to remember which. It's always difficult to keep 53 different countries in your head at one time. But certainly it has been shown that you can actually get children of a really quite young age to wear them.
Yeah, I think that's...
I have to say I'm not sure actually in Ireland why that is. It's not, I know it's not in the guidance, but I don't know why it's not been included.
The messaging around masks in Ireland has been shifting. The original HSE ads were to wear masks in shops and on public transport. And the last few days, they have changed to wearing masks in shops and in crowded areas, indoors and outdoors. So I think we've been pushing wider use of masks for quite a while, and not ourselves, though many other people have been pushing it. So that may be gaining some traction.
I've been I primarily deal with workplaces in my department, but I've been pushing that for quite a while in open plan offices, everywhere from offices to factories, where a number of people are in the same room together. Even with distancing and with a new variant in the mix as well, I don't think there's enough protection without mask. And I've said this quite openly a few times, and I've communicated this as well up my lines as well. It just needs to be in place. It's just another layer of protection for workplaces.
Yeah.
Yeah, I mean, the WHO guidance is clear that children over 11 should just be treated as adults in this respect. Children 6 to 11, they set out a series of considerations which is related to the extent of transmission in the community and access to masks and adult supervision and so on. But WHO and UNICEF have pulled all of that together. So, but there are certainly a number of places of jurisdictions where this is the case. And but the other thing we shouldn't forget is ventilation. Again, as we're coming into warmer weather, then I think we need to look again at ways of maximizing ventilation and all of the other things that can be done to make schools safer.
Yeah, I think that is part of the message, is that we have to do there isn't a magic solution to schools, but it's doing a lot of different things, and doing all of them will be very helpful. There's a question from Bernard Doherty, which I might skip on to, which is just about that. And it's asking, in relation to schools returning, are enhanced public health systems in place for tracking and tracing? And perhaps if Marie, if you could answer that briefly.
Well, within each regional department of public health, there are schools teams. So there are some ex-teaching staff who actually work with a public health specialist, and they have a protocol for contact tracing that they undertake. I'm not involved in that directly myself because I do other areas, but there are teams in place, and they've been kept in place since last year. So, which is a good idea.
And there's another question, I think, directed in your direction, Marie, from Joe Noonan. What could be done by the powers that be in the Department of Health and Finance that would enhance your work and that of your public health colleagues?
Well, I think the staffing issue is one in the consultant contract that would stabilize our workforce at the moment. That's the first thing. I think the second thing is we need to regionalize our contact tracing. So the centres can remain, but we need to have allocated work contact traces for each region, because I think that will contribute to our own understanding of transmission, and it will also help with source investigation as well. I think the other thing too is we actually need to have some proper support systems in place for public health. So we need that IT infrastructure, because we also need to develop a national immunization system too. We don't have that either. You know, that's still on the shopping list, and that's important right now, especially in a multi-dose vaccine. This and maybe with the down the line there may be requirements for people to show evidence that they've been vaccinated, so a system will be needed. The second thing is we need to have more proper HR, someone responsible for that and a team for that, to get our staffing sorted quickly, because we seem to be kind of running into recurring issues and they're slow to resolve. And I think another thing is that we need communication support as well. We've never had communications staff in public health, which is a bit of a disaster during a pandemic. In our department, we've used our ability to hire temporary staff. We use that to hire a communications person. So you can probably see my department in the press quite a bit, but that's because we have a comms person, which other departments don't have. And I think that's really important at the moment, because I don't think national messaging is specific enough for people in regions. I think they need to hear more what we see on the ground. And I observe changes in behavior fairly quickly from talking to people, and I observe changes in pattern and as well, which are important to communicate about fairly quickly, far quicker than you will see in the data at a national level. So I think that's really, really important. And I think, well, the IT infrastructure has to be sorted as well. Our national contact tracing system at the moment is very national based. It's not regionalized. So, I can't go into the system, pick out all my cases from my region. Everything is just into one pile. It's very hard to get information or data out of it. We can't take any data out of the system for ourselves to use at a local level.
Yeah.
So the system is very much designed with a national focus, but we need to actually regionalize that and enable us to use the data for our own metrics as well, and to help us investigate and understand what's going on in our region. So there's a substantial amount of work to do on those things. I think if we got that, Joe, we'd be doing really well.
Joe has managed to sneak in two questions, so one of which has been asked by somebody else as well. So the second one is for everybody. In relation to the plan the government brought out yesterday, do you see significant improvements in it? And if you'd written it, what are the big differences you would have written into it? So that's open to anyone to respond. So just unmute yourselves. And
I might have to confess to not having done my homework. I actually haven't read it yet. I haven't got to it yet, but
I've been rather busy with the plan over here, which I've been rather busy with the plan on this side of the water, which is at the best, let's say, work in progress.
Okay.
Anyone else? Any other thoughts? Trish?
Has anyone else read anything?
What are your thoughts on it?
So I think, I would welcome a lot of the decisions that are being made, the focus on data rather than dates to guide the decision making. But from a, I suppose, personal and scientific perspective, I think the one big thing I would ask for is a strategy. So we're talking about tactics, not strategy. It's not clear what we're working towards. We're continuing to persist with this language around living with the virus, and we've very clear evidence that that doesn't really work very well. And so the one thing that I would ask the government to do differently would be to have a strategy, which would be to aim for elimination.
Yeah. Any other thoughts or comments on it? Eva or Claire or Paul or Andrew?
Well, I think, yeah, there was a tacit admission in the document that living with the virus doesn't work, because they have a phrase where they say something along the lines of, we have learned that it's not possible to have moderate levels of infection, that it doesn't stay moderate for long, and this virus, grows in numbers once it's given any space to do so. So I think it's welcome to see that recognition. There are welcome points they talk about. They mention public health and how it's going to need more resourcing, and that's a priority. They don't provide detail. So they say a lot of what you might feel like a lot of the right things. But and they, in their speeches, they say we're going to base this on the data, not the dates. But the only things in the document are dates. So they mention some metrics that they would like to use. So they say it'll be down to case numbers, the R value, hospital occupancy, the vaccine progression, rollout progression, and also potentially something to do with new variants. But they don't give any parameters there. They don't say, when these numbers are even in a zone, like they don't even give an area where it would be possible to start making some movements in terms of the restrictions. So even though they said in their speech, it's the data, not the dates, the only things they provided were provisional dates. And they didn't tell us anything like the criteria under which those provisional dates will become real dates. Another thing, they don't do anything new with regard to hotel quarantine or mandatory quarantine. They just mention what they have previously done. And there was Leo Varadkar was on Morning Ireland this morning, and he mentioned the idea of, so when the presenter said to him, you just listed a few countries for quarantine, why don't you treat all countries the same? And he said, well, we shouldn't be treating the Isle of Man and Iceland and New Zealand the same as other countries. And he mentioned even travel bubbles and things like this. It's like, these are exactly the countries who will not accept us into their bubble. Yes. They're not going to want to bubble with us.
It does take two to bubble.
Yes. But in any case, so that's a good principle, but it doesn't apply to us. And the Isle of Man got to that position exactly because they did have quarantining. I think it should be like, it took him 3 seconds to list the countries that you wouldn't need to restrict people from. And I think that's the way they should be thinking about it. It should be for all countries except the following, if that's what they want, rather than just listing the countries you should be restricting people coming from. Because as we know, these new variants are very troubling, and they not only create a worse disease situation potentially. I mean, there's several of the variants that we're worried about in terms of what they do. Just simply in terms of increased transmission is already a problem, of course, but then there's worries and also to do with the morbidity and the mortality, and that's not known concretely yet, but we don't really want to wait until we know that for sure. And then of course the vaccine efficacy. And the government strategy appears to be entirely based on the vaccine, in which case they should be doing everything they can to protect the vaccine. And that the vaccines are amazing, they're wonderful, and it's so good to see how well they work. It's so good to see the news about the reduction in transmission. That's amazing news. It's brilliant. So we should be doing everything to protect that strategy. And I would see that, that they're not doing that as far as I can see. But the other thing I'd really like to see is some, regional kind of green zone, regional relaxation, because you have counties, and I think it's in one of the questions, perhaps, Kerry's doing the best of all the counties at the moment, if you counted per capita. Cork is doing quite well as well, and Kilkenny. But Dublin's the worst. Do we make them wait until Dublin is ready, or do we say, well, if we're opening Kerry, we have to open Dublin as well? Neither of those is a good solution. So I think they need to think a bit more regionally as well. And they did it before with the Lee Shoffley Kildare. They showed that we can have different restrictions in different parts of the country. And,
maybe turning to Cork, Ivan Perry has his hand up. Do you want to unmute yourself, Ivan?
Hi, Anthony. So first of all, I'd like to thank Martin and Mary for two really excellent talks, excellent presentations. And Mary in particular has highlighted the stark consequences of the investment in public health infrastructure, over decades, and the issues that Mary has raised, particularly the lack of investment and the lack of recognition of consultant status, have been highlighted, and have been campaigns on these issues for at least 20 years, and yet they remain largely invisible. And I'd like to Mary's thoughts on how we could make these issues more salient in the current discourse on COVID. I was discussing with a journalist in one of the national newspapers last week who had no idea as to what public health doctors actually do, and I think that, and I know that part of the problem is that the small group of current public health doctors that we have are so busy they haven't had the time to be as visible as perhaps, although Mary yourself, you've been very visible, and I'd like to commend you on the way you've campaigned on some of these core issues. So really, I just think that for us at ISAG, we need to start. We need to come to a point where, say, in the interview on Morning Ireland this morning, I keep waiting for a journalist to ask the Taoiseach or the Taoiseach, why aren't you supporting our public health doctors? So I think that this is a practical campaigning issue that we haven't yet cracked.
Yeah, I actually don't know if I have an easy answer to that one, Ivan, because I was talking to somebody recently who a member of the public who wanted to support us, and they wrote to their local politician, and the local politician responded that, oh yes, of course I support public health doctors who work at our hospitals and, provide, care to our public patients. So I suppose I'm kind of a one-woman campaign about how we actually work and what we do. I suspect it's true. Like, my colleagues are busy. I tweet at night after I put my toddler to bed to raise awareness about it. But I think there's a fundamental disconnect between public health and political objectives, in that politics is very temporary and very short term, and public health is about building for long term. Like, because we're concerned with issues like, obesity, we're concerned about issues that climate change, those kinds of things, air pollution, all kinds of things that have a longer term impact. Yet politically, you're much more likely to spend a bit of money on a new scanner or a new robot for a hospital than you would for somebody like myself or staff like mine. I suppose what worries me about public health is that the skill sets we need now really have to rapidly evolve to match the kind of public health challenges we have now. They are our own views of public health, and what kinds of staff we need to really change as well. We need a far greater diversity of skill set, and far more than we have planned for now. Even we need big data scientists. We need people who are looking at analyzing data that isn't just infectious disease data. We need to be looking at behavioral science even more, and anthropology and sociology and all kinds of things. I think the environmental scientists as well are very important at the moment, with ventilation elements, like their research and recommendations need to be incorporated too. So like, the breadth of public health is wide, and it's just it's hard to imagine how we're going to get that together into a vision. I think we just need people to keep supporting us from the public. We just need to keep talking about what we do, and how we contribute and how we lead on these things as well. But maybe we need to hear from more than just myself. Maybe
Martin,
Ivan, you will know, you were frontline for a little while as well. You came back to us for a while there at the start of the pandemic.
Yeah, and indeed, during my brief period of frontline, I learned how to use my phone's hotspot, because the environment I was in, although the people were excellent, there was no Wi-Fi for several weeks.
No, there isn't. Yeah.
At the start. But I think your point about the multidisciplinary workforce, and I know you're aware of work we're trying to do on this, because we and others have been producing BSc public health graduates and MPH students, so the graduates are coming out, but we need proper career structures for them to populate these multidisciplinary teams.
Martin, I think you wanted to say.
Yeah, just as background, I chair the Scientific Advisory Board. I'm a commissioner on the Monti Commission, chaired by Mario Monti, which is on the future of health and sustainable development in Europe. And I'm one of a very small number of health people on it. It's mainly, we've got 2 former prime ministers, 3 former presidents, central bank governors, people like that. And the issues that we're talking about, which are directly relevant to public health, are looking at international trade, we're looking at international law and governance, we're looking at political science, all of these issues. And in this commission, we're actually not talking about what needs to happen to the health system going forward, because we're taking that for granted. We're saying, how do we create a wider environment that supports inclusion, which means we need to look at welfare policies, we need to look at fiscal policies, taxation, all of those issues. We need to look at the role of the international financial institutions. Why doesn't the IMF include health in its Article 4 consultations with governments? Why isn't health policy included in sovereign credit ratings? We're looking at creating a climate for innovation, not just for health, but for everything. Because if we do that and we look at intellectual property and incentives, that will help health as well. We're looking at ways of promoting investment again. So, these are the sort of big picture issues. And I think in public health, we've often we've lacked confidence, actually. We either haven't had developed the skills, or when we do get into those environments, we sort of we pull back and we say, well, I wouldn't know about that, or I wouldn't understand that. But actually, as I say to my students, if you watch BBC, God help you, but if you watch BBC Question Time, which is a program we have one night a week here, and you look at the complete idiots who stand up, who's there and talk about things they know nothing about with supreme arrogance and confidence, then you realize that actually we can do 10 times better than that. So I think we need to look at not just our training, but also our willingness to engage in some of these issues beyond the traditional, not forgetting that we need all the public health skills too. We need the EPI, we need the stats, we need the other things, but particularly we need to be looking much more at artificial intelligence, large data, and all of these things, communication skills, cognitive biases. Why is it when we say something to a politician, they hear the opposite, and so on.
Okay, so I think that puts it in a nice context. I'm going to finish up with one very difficult question, which I understand the situation that the gentleman is asking about. So Brendan O'Gara has asked us, he's a dentist, he's over 55 and he's off work at the moment because he thinks it's too dangerous to carry out dental practice. So he's concerned, he's asking a question about vaccinations, and particularly if the new strains are emerging, and there is some evidence that existing vaccines do not provide optimum protection against the new strains. Should he get vaccinated now? Is the question he's asking. So would anyone like to answer that? What's the most sensible thing to do in terms of being vaccinated, given the current situation and given the risk that future strains of virus may emerge, which are not covered by the vaccine?
I mean, almost certainly we're going to have re-engineered versions of the vaccine anyway, but I would just get vaccinated as quickly as possible, because even if, the difference between, the results we're getting in the AstraZeneca and the Pfizer-BioNTech and the Moderna are actually not that much. And it's only by measuring antibodies, the antibody titers, that we're seeing a difference, where it's not clear that will necessarily translate into a huge difference in actual protection. And then, some of the evidence is suggesting that there isn't that much of a difference. So yeah, I would go for it. I think you're going to get substantial protection. Yeah.
I agree. The best vaccine is the one you can get soonest at the moment. You know, the
Exactly.
numbers are still high. You know, it's the best, the one you can get as soon as possible is the best one for you.
And that's why
Um,
we've been supporting the UK government's approach, which is to delay the second dose to get more people covered. If you've got 100 doses of vaccine in 100 people, it's better to give 70% protection to all of them than to give 80% protection to 50 of them and leave 50% unvaccinated. We need to get the second dose in, of course, but you know, the thing is to get as many people covered at least partially as possible.
Yeah, I mean, I would agree with that. I'm not sure I agree with what the UK is doing about that. I think there are other risks there. But I think in terms of getting vaccinated, the evidence is really clear that vaccination reduces, if it does nothing else, it reduces your risk of dying.
Exactly.
And your risk of getting seriously ill a lot.
Yeah.
And that is a benefit worth having, because this is a nasty, nasty, nasty illness. And you do not want to end up seriously ill in hospital, or God forbid, critically ill on a ventilator, or worse yet, dead. And the vaccinations, all the vaccines that are available, will reduce the risk of that happening to you. I'm going to finish now by, first of all, saying thank you very much to Marie and Martin for two really good talks that I think have focused our minds on public health sides of this. I'd like to thank our participants for some excellent and challenging questions. I'm just sorry we didn't get round to more of them. I know some people have to go now, but we may continue discussions for a little while longer. And thank you both very much.
Thank you.